This was honestly one of the first times I've actually had to diagnose a patient. It felt really good to sort of hear the patient's story, ask some more questions, and then use physical exam skills to figure out what was going on. What is up, everyone? Welcome back to the channel. For those of you who don't know me, my name is Jordan, and I'm a second-year medical student in the state of New Jersey. So in today's video, I want to talk about all the different clinical things I've been able to do in the first few weeks of my second year. So the first thing is during, I think it was our second week of this current course, we had a clinical skills day that was called Approach to Abdominal Pain. So we've already done a lot of these sessions throughout our first year, approach to chest pain, approach to shortness of breath, all that kind of stuff. So today was abdominal pain, and it makes sense because we are currently in our GI block. So we had previously learned the abdominal exam. That was something that we learned in our anatomy course when we learned sort of the basic head to toe physical. There's not too much to the abdominal exam. You basically listen to the stomach, percuss, palpate, try to estimate how big their liver is, see if you can feel their spleen. So compared to the heart and lung exam, it's really not that bad. But the point of this session was to bring in the clinical aspects. During our anatomy block, we weren't really learning about different diseases or things that go wrong with the GI tract, so that was what this day was about. So first, we started in a small group and just went over a bunch of different common causes of acute abdominal pain. Had a refresher on the basic abdominal exam, and then also learned a bunch of sort of special maneuvers to specifically look for different pathologies. So we learned the obturator sign, which is a thing that you can do to check for appendicitis. That's when you lift the leg up and internally rotate the knee. It's supposed to sort of put pressure on the obturator nerve, which goes right by the appendix. So if someone has appendicitis, it will hurt a lot. We also learned something called the Murphy sign, which is to check for a gallbladder or liver issue, where you sort of put your hands right underneath the rib cage and have them inhale. And it's sort of supposed to push the gallbladder and liver down into your hand. And if something is inflamed, they're going to feel a lot of pain. So aside from learning all these different physical exam maneuvers, we also talked about how important it is to take a thorough history with abdominal pain patients. There's a lot of social factors that can come into play with abdominal pain. So you can ask about things that they recently ate. You can ask about their alcohol intake. Excessive alcohol intake can lead to something called alcoholic hepatitis, which can present with severe abdominal pain. We had standardized patients who were presenting with acute abdominal pain, and we were able to localize it to her right upper quadrant. So it told us something was wrong with either the gallbladder or the liver. And after asking some questions, we discovered that because of how much she drank, it likely was alcoholic hepatitis. One thing that we talked about throughout all of these approach to sessions are don't miss diagnoses. These are certain conditions that you need to 100% rule out because of how dangerous they are. So for example, someone coming in with chest pain, one of the don't miss diagnoses is a heart attack. For shortness of breath, it's a pulmonary embolism, a really dangerous thing that can kill you if you don't catch it quick enough. Cancer is another thing that should probably always be on your differential no matter what. It can present in a lot of different ways, so it should always be in the back of your mind. We learned a few don't miss diagnoses for abdominal pain. One that you have probably all heard of is appendicitis, which is inflammation of the appendix, and it can be really dangerous if you don't treat it. Another don't miss diagnosis that presents very similarly to appendicitis is an ectopic pregnancy. This is when an embryo implants in a fallopian tube instead of the uterus. If it ends up implanting in the right fallopian tube, then both ectopic pregnancy and appendicitis present with pain in the same area, which is the right lower quadrant. This is another reason why it's essential to take a good social history, like asking about their sexual history. One of the best ways to quickly differentiate between these two things is by doing an abdominal ultrasound. If they have appendicitis, you'll see that it's big and inflamed, and similarly, you'll see a enlarged fallopian tube if it's an ectopic pregnancy. The treatment for both of these is kind of similar. Basically, a surgery is required to remove the affected structure, because if you don't, they could rupture and cause some serious complications. Another exciting clinical experience I had was I went into clinic last week for my longitudinal clinical preceptorship. I work with an IM doc who mostly does outpatient primary care. Sometimes she goes into the hospital, but for the most part, I'm with her in her outpatient clinic. I think this was my 7th visit, so I'm really starting to get a hang of things and starting to learn her workflow. It's apparently a big thing once you start rotations. You gotta learn how the attending and the resident like to work so you can appropriately integrate with that team. It was great to be back in person seeing real patients after summer break. While the clinical training we get at school is helpful and that's how we learn a lot of the basics, nothing compares to interacting with real patients. We had one patient who is a nursing student and is about to start her clinical rotation, so she needed another series of the hepatitis B vaccine because she's not immune anymore. So I was pretty excited to give her that vaccine. It's only the second vaccine I've ever given. However, when we were talking to her, just seeing how she was, she mentioned that she'd been feeling pretty dizzy recently, especially when she stands up, and it's so bad that she had to go to urgent care and the ER. At the urgent care, they said she probably had something called orthostatic hypotension, but at the ER, they said she might have something called POTS, which is postural orthostatic tachycardia syndrome. Both of these things are pretty similar. They cause lightheadedness when you stand up. So it kind of makes sense why the urgent care thought one of them and the ER thought the other. So just for some background, I'm sure there's been 1 or 2 times in your life where you've stood up really fast and gotten lightheaded for a few seconds. But thankfully it goes away pretty fast. For someone with one of these 2 conditions, it doesn't go away fast, if at all. So when we've been sitting or lying down for a while, our heart and our blood vessels kind of get used to that state. And when we stand up fast, it's sort of changing that equilibrium, and we're supposed to respond to it. We have these things in our blood vessels called baroreceptors, which sense changes in blood pressure and tells our blood vessels to change how tight they're squeezing to respond properly. Normally, when you stand up, your baroreceptors sense that your blood pressure is going down and they squeeze a little bit tighter. In people with orthostatic hypotension or POTS, this system isn't working well. For people with POTS, since their blood vessels aren't constricting properly, their heartbeat speeds up to compensate for it. But in people with orthostatic hypotension, none of these systems are really working. So in addition to giving the vaccine, my attending wanted me to try to see if I thought she had orthostatic hypotension or POTS. The way you do that is you take the patient's blood pressure and heart rate when they're sitting, and then you have them stand up, and then you retake it. So I did both tests, sitting and standing, recorded the numbers, and then walked out of the room. I didn't remember the exact numbers for the diagnostic criteria. I knew for orthostatic hypotension, the blood pressure was supposed to drop by a certain amount, and for POTS, heart rate was supposed to increase by a certain amount. So to make sure I was getting the numbers correct, I looked up the diagnostic criteria on Amboss on my phone. This has already been a lifesaver so far, and I know I'm gonna use it all the time during rotations. So after looking things up for orthostatic hypotension, you need a decrease in your systolic blood pressure of 20 when you stand up. And for POTS, you need your heart rate to increase by 30 beats per minute when you stand up. Unfortunately, she didn't perfectly fit either of the diagnostic criteria, but she was a lot closer to orthostatic hypotension, so that's what I told my attending I thought she had, and she agreed with me. This was honestly one of the first times I've actually had to diagnose a patient. A vast majority of the patients that I've seen in the clinic have been just like establishing care or following up on something, so I haven't had the opportunity to diagnose anything. It felt really good to sort of hear the patient's story, ask some more questions, and then use physical exam skills to figure out what was going on. So that patient encounter got me even more excited to start clerkships. All right, and the third exciting clinical experience that I've had over these past few weeks is we had a clinical skills showcase. Basically how it worked was we got to sign up and go and play with a bunch of the fun toys that our school has. I've already used some of these, like the high-tech mannequins, so I tried to stay away from those and use things that I hadn't before. And a lot of the stuff is things that we will start to use once clerkships start, especially in November. We have something called a transitional clerkship where we learn a bunch of physical exam skills to prep us to start clerkships. So I started in a room that had a model arm where we learned phlebotomy, something that I've seen a lot when I was a medical assistant, but I never learned how to do myself. They also had an intubation station. I could not get it, but a few of my classmates did. One of them wants to be an anesthesiologist, so it's perfect for him. And then there was a model for a pelvic exam, and they even had like fibroids inside of the uterus for you to find and see what they would feel like. One of the coolest things was a simulated delivery. It was another one of the high-tech mannequins that simulated someone giving birth. So it teaches you like the proper technique of how to catch a baby. And this is apparently something that we will do on our OBGYN clerkship. We all have to go in small groups with the OBGYN clerkship director, and she teaches us like in depth how everything works. That day was just showing off the technology, and we did get a little bit of instruction from the tech, but nothing like we'll get from the clerkship director. And then the last thing was a suturing station that was actually in like a mock OR. I didn't even know this existed. It was in an area that I'd never walked around to, but there was literally like scrub stations like you would see in a hospital or surgery center. And then inside they had like an operating table, like OR lights, the whole 9 yards. I talked to one of our clinical skills directors, and he was saying during our surgery clerkship, we sort of have a mock surgery where we scrub in outside of the room, go in, and then have to suture up pig's feet, which is a common thing that people use to practice to suture on. So really excited for that. Surgery is my second clerkship, so I'll probably be doing that in like 6 months. So all in all, has been a very exciting start to second year in terms of the clinical experience. I only have like 10 more weeks of class before we start that transitional clerkship, so there's a bit of a light at the end of the tunnel, because I know myself and a lot of my classmates are just itching to get to clerkships. All right, well, that is gonna do it for today's video. If you enjoyed, please be sure to leave a like below and subscribe if you wanna see videos like this in the future. Thanks, and I'll see you in the next one.